got a couple other folks who have joined us. I've given instructions to people to kind of hover over your name at the top right corner and rename yourself and at least put your state by your name so we can kind of see where people are. I'm gonna give one more minute and then dive in to our 90-minute session here on Medicaid and home and community-based services. And I am intending this session to be fairly dynamic. So you will not be suffering and subjected to me talking the entire 90 minutes. We've got 3 core topics and discussion questions embedded in. I'm going to try and run this session as some of you who may be familiar with Jeremy Norton-Paul's peer-to-peer networking for policy networking for states. We're kind of going to run it like that. So there'll be a little bit of talking, but if folks want to use the chat, sometimes people have things that they've done in their states that they want to let other states know about or have questions that they want to ask. We'll use that chat and then we're going to build in discussion time around each of our topics. So I'm looking forward to hearing from all of you as well. And it looks like we have a number of other folks that are just joining in, so we'll wait another couple of minutes. Molly, I'm going to start sharing my screen, so if you can watch and make sure anybody who's waiting to get admitted does.
Okay, sounds good.
My goodness, I'm not seeing my presentation on my share screen thing. There we are. That's the problem when you have so many windows open, is that you end up having to go through pages and pages of things to share your screen. Okay. So welcome everybody. I'm going to get started. It's 3:02. For those of you who have just joined us, a little housekeeping. Please rename yourself so everybody knows what state you're from. And for those of you who have been a part of Jeremy Norton-Paul's kind of state peer-to-peer group on public policy, if you're not, I highly recommend they're fun calls. If you need another call to do, please join them. We're going to try and run the format of this presentation very similar to that. So oftentimes I have 3 topics that we're going to be kind of going through, and I'll do a little discussion, but we're also going to build in plenty of time for not only questions, but discussion items. And a lot of times we will use the chat function. So if you have resources that your state has done that you think would be valuable to other states, or something to share, or questions, please do use that chat. I, of course, will not be able to see it, but Molly's here and she'll let us know if there's something that we need to kind of stop and address right away. Otherwise, we are going to be building in some time on each section. So without further ado, Today we're going to talk about kind of 3 core items that I think a lot of states are thinking about at this particular moment in time when it comes to especially home and community-based long-term care services. Many states have Medicaid waivers for various populations. Some states have a lot of waivers, some states have fewer waivers, but all of them use a Medicaid authority to essentially operate their adult long-term care services, which is where a lot of people with intellectual and developmental disabilities are. As part of what has happened during the pandemic, we have all learned about Appendix K, which is that magic appendix that I think all states applied for during the pandemic time to allow their waivers to be more flexible. Some of those are now expiring. So we're going to talk about what is that, what kind of advocacy opportunities does that mean for states. There's also been kind of an ongoing conversation about home and community-based service models, and specifically for those of us who have been around longer than we'd like to admit, some of you may have heard about the home and community-based settings rule, or lots of other discussion about, is what we do right now as part of home and community-based services community-based enough? So we're going to talk a little bit about, are there opportunities, especially as we've learned about, seeing what has happened in our states during the pandemic, to kind of, as Julia Bascom said yesterday, rethink what we consider community and how we evolve our system to be much more like what people without disabilities expect. And the final topic that we'll spend some time on is protecting home and community-based services. Many of us have a variety of congregate settings that are operating in our state. Some are large-scale institutional settings, some are smaller scale, and certainly there are lots of states that are facing the reemergence of segregated settings as being a policy option. So we're going to talk a little bit about what might be some strategies on that. I am from Wisconsin, so my lens sometimes will dip in there, but I am trying to create a presentation in a space that is useful for all states. So you won't be hearing too much about, well, in Wisconsin, this is how we do things, because obviously for the other 49 states that aren't Wisconsin, that's really not super exciting for you. So moving to the first topic, Appendix K. Most states, as I said, have created home and community-based waivers using the 1915 C authority. And Appendix K is kind of the shorthand for how did we figure out how to make our current waivers more flexible in a time during COVID when everything changed. Most of the time, Appendix Ks are used in response to temporary emergency situations. And they're always temporary, they're always time limited, and they're always asking CMS for flexibility in terms of how they operate their normal waiver with CMS for that specific period of time. One thing that is, unusual, nobody's ever used an Appendix K for a pandemic before because we haven't had one before. So this is an authority that very typically might be in response to a wildfire or a tornado or a flood where you're expecting temporary disruption of services that come online fairly quickly. Maybe you have a period of 3 to 6 months or shorter where you really need some localized changes to respond to a situation where things are disrupted. That is very different from what I think most states' experience with COVID-19 has been, where we really had to figure out how do you shut down in many ways a lot of especially the congregate services that many home and community-based long-term care systems provide funding for. And also, how do you sustain those providers who aren't providing services because it is not safe from a public health standpoint to do so. So now states, we are now almost a year beyond when most states started to have their waivers, their K-waivers approved, and many states have expired or decided that they no longer have a state of emergency at the moment when it comes to COVID-19, and that's the ability, that's really what triggers the Appendix K flexibility. For those of you who are real nerds, which I'm sure you all are like me, there's a link that Advancing States did that kind of outlines what are the various emergency Medicaid waiver authorities and what are they triggered by at the bottom of the page. So now many states are in a place where they have had Appendix K waivers and the flexibilities that are tied to that waiver that are now at the point where the state has to decide, are those flexibilities going away? In other words, are we going back to the waiver and the rules as it existed before COVID-19? Or are we going to decide to keep some of those flexibilities in our waivers going forward and not keep others? Or are we just going to do everything that we've gotten used to over the past year permanent? So what are some of the things that states have used Appendix Ks for? I'm not going to spend a ton of time on this, but there's a lot of things that most states tried under Appendix K. And for a lot of states, because this emergency has been sustained, it actually did give you some amount of data about how well does this work in a way that perhaps other emergency situations might not. So you can kind of see in that left-hand column, okay, what does a K waiver allow states to do? Some of the common flexibilities that most states tried: telehealth, virtual delivery of services. How do you do remote consults? How do you do, administrative functions like signing things without having to be in person? Lots of states decided that paying family caregivers was a thing that they could do during this moment in time. How do you sustain direct care professionals? And a lot of these things, not only states, but NACDD said some of these things are actually really valuable and improve the lives of people with IDD. So, lots of when we talk with other states about, well, how has Appendix K actually benefited people with IDD, a lot of times people will say, like, look, some of the administrative requirements that states have put in place that require in-person contact, maybe now that we've spent a year on Zoom, and I will be the first to admit that I've spent a year on Zoom and it still takes me a while to figure out how to share a presentation every time I do one. But a lot of people have said, hey, maybe we don't need to do in-person everything. Maybe we can, there are some things that are really about the agency having permissions that don't need to involve a big, mobilization on terms of the participant to get there in person. Maybe there are some remote support technologies that might actually help ease our workforce crisis. If you don't need 24/7 staffing for somebody, if you can maybe do a shift where there's a remote monitoring system, for example, overnight, that can be a huge savings. And there are privacy challenges, but also privacy advantages to that approach. A lot of people with developmental disabilities, as many of us as well, figured out there was a lot of stuff we could do remotely, provided we had internet connection and other things, including banking and ordering groceries and a lot of entertainment stuff, etc. Is that helpful to self-direction? Maybe so. So what is the role of councils now when we think about how states have used Appendix K in the last year, and what, if anything, should they be looking at in terms of evolving their system to be more like what we have experienced in the last year, or at least the good parts. So states can choose to permanently keep these flexibilities. All they have to do is amend their permanent 1915C waivers and state plans to do it. And most of us who have been working in this field for a while understand that the state Medicaid agency negotiates with CMS, and there's a process of approving a waiver. And some of us would gripe that they don't necessarily involve the advocates in every step of that process, but that's what needs to happen if the state wishes to continue these flexibilities. My state, and there are some others, if there are substantive changes to waivers, sometimes have a legislative oversight process that adds in time, and may add in some necessary, discussion with the legislature to make sure they understand that we're, not actually doing something that's disruptive. Our council and others across the nation have figured out that, we need to be proactive when we work with our state Medicaid agency, not only in asking, hey, when are these deadlines coming up? When are these things expiring? Are you going to be extending some of these flexibilities? Because they don't necessarily think to ask or tell us. But it's also really important for Medicaid agencies to hear from councils what have been the things that have really been helpful to families and people with IDD in their lives in this past year. Because it's a perspective that we find, at least in our state Medicaid agency, there aren't too many people working in that agency that actually have direct contact with the people who are in and using these long-term care programs. And they really rely on us to help them understand how, what is it about these flexibilities that makes them useful to real people in their real lives. The other piece that is worth being aware of, and it's actually coming from one of our colleagues on the East Coast, sometimes they don't tell you they're not continuing the flexibilities too. Unwinding is this phrase that you may hear, and it really means like a state is deciding that there are certain flexibilities they're not keeping. So they're kind of all of the processes that they put in place to help that flexibility happen, they're now doing the opposite thing, where they're kind of making a process to unwind that change. And that can present its own set of challenges too, and its own questions that DD councils can be very helpful in helping the agency ask and consider as they're deciding if they're stopping a flexibility, how to do that. Most of us don't go from 0 to 60 when we step on the gas in our car. It's also hard to go from 60 to 0. And there are some states where they haven't really thought about, oh, we're stopping this flexibility. What does that mean for provider agencies who are now used to billing in a certain way because they've been doing that for the last year? And especially self-directed programs where you may have people who, have perhaps been paying family members or doing other things for now quite some time using a process that they've gotten used to that is now going to be stopped. We've also found in our agency, and I hear this from other states, that communicating these changes to the actual people who, to provider agencies and to participants is not something that the state Medicaid agencies necessarily do well or early or often enough. And they often aren't doing it in plain language. Our agency likes to send out letters in bureaucratese, and they wonder every time why people don't understand what is happening. So, those are all kind of very key things that councils can be actively engaged with as you think about what's, now that now that Appendix K may be going away, what does that actually mean for the people who are in the program? Okay, last thing before discussion, and then I'll show you slides. I hadn't put this slide in until yesterday, but the pandemic isn't over. And I think that, when states declared their states of emergency, got in their Appendix Ks, there's a time limited amount of time of a year. I think people originally thought, well, that'll probably be a long enough time to deal with the pandemic. And it may or may not be. I think this is more variable depending on where you live. Certainly we're having conversations in our state about what is the Delta, the current variant. There may be others in the future, right? What does the current variant mean? Especially for our unvaccinated populations, many of whom are workers who do direct service with people with disabilities, honestly. And does this mean that we're going towards a path where either there's going to be another state of emergency that is declared, or there isn't, right? Which for our state is more likely the political reality. I don't know how bad the numbers would have to get before our legislature and our governor would agree that there is an emergency that is in fact occurring again, and whether the legislature would agree that our governor could declare an emergency for what they see as the same emergency that never ended. A little bit of editorializing, but I think other states are also finding themselves in the same political place where you have numbers that can go up and the same emergency essentially happening. And what does that mean when it comes down to, do you need to activate these flexibilities again? So again, as you as a council are thinking about it, yeah, you can advocate to your governor's office, what do you do about emergency declarations, and why would an emergency what would that emergency declaration help you to be able to do? You need that in place before Appendix K, for example. If your governor isn't going to do that, there may be other public health responses that need to occur, and it may make a better case for your state to look at what they did in Appendix K and actually amend their permanent waiver, so that you never have to go through this negotiating back and forth with CMS about whether or not you can make things more flexible. You may also have an opportunity to think about, how has COVID actually changed your state's long-term care landscape? Unfortunately, we've had a lot of providers that haven't made it through the pandemic. We knew that was going to be a problem for lots of reasons. What does that mean going forward in terms of innovating our system, developing capacity and new quality providers, quality being an important word? What does it mean for how we need to think about our workforce? Not only what are they paid and what are their benefit packages and other things, but what are requirements for vaccines going forward as we are continuing to experience variants and the pandemic. I'm going to go back to that discussion. I included about 6 slides that I'm not going to go through, but you're going to get the presentation. NACDD actually did a pretty detailed letter to CMS that outlined some very common things that states had used Appendix K for, and then provided some framework and advice of what are the advantages for each of these flexibilities and what do you need to consider before approving them. So we've got about 6 slides in here on virtual services and telehealth and paying family members for support, and a lot of the common things that we've heard from councils that I won't go into now, but it's there for you. So I'm going to stop talking. We have about 10 minutes, and then I'll go to our next topic. I've kind of done some, overarching discussion questions, but I'd like to open it up to you guys to talk about what you're thinking about when it comes to on winding down or up on this pandemic.
Can we just come forward with our question? It actually speaks to number one on your discussion section here. What are your thoughts on the flexibility for people with disabilities and families to continue to have the support offered by the direct care worker wage increase?
So are you talking about, like, some states have used their flexibilities to enhance workers' wages? Like,
Yep.
with that's the,
Mm-hmm.
I have a couple of thoughts. One is going into the next section, which is, okay, how do you sustain, if you found it valuable to increase those workers' wages or provide bonus payments or retention payments, how do you sustain that funding stream? And I
Yes.
think there are several options for states. First of all, there's always the state budget process, which won't necessarily help you if if the Appendix K is going away real soon and your budget process is not ongoing. But I do think there's a lot of room for, should rates increase for providers, should there be a pool of funding for bonus payments or other types of workforce stabilization approaches. Our state did a caregivers task force that came out with like 40 recommendations, and it's not all about the pay. I mean, it is somewhat about the pay, but there's also other things states can do to, say, provide healthcare benefits or retirement benefits or, more radical solutions. So there's always a budget or a legislative opportunity. That being said, I also think this is a great time to start talking about, how is your state going to use that 10% FMAP bump that you got through the previous COVID relief bills? And that's kind of our next section. As well as, hey, Governor, you have a bunch of discretionary funds for ARPA. How are we going to think about using that money over the next 4 years? And I want you to be thinking about, like, how do you do, that's limited time money. So how do you do the things with limited time money that puts you in a position to be in a better place to advocate for a better longer term solution for the workforce?
Okay. Thank you.
Do other folks out there have ideas about that, or concerns about, how your provider workforce looks on one side of the pandemic versus the other? Guys are really a quiet bunch and a bunch of thinkers today. If it's okay, we can be ahead of time. That's an okay thing to be. So I might just put my timer back on here and get us to the next section. I think these are all questions that you can take back to your councils and kind of think about, or your coalitions. So I don't think there's anything like you have to answer it right away. And I'll go on to the next section, and then, you know, perhaps we'll have a little extra time at the end for questions. So these are the slides when you get the presentation. Again, some of the things that our NACDD Medicaid subgroup of the policy committee, you know, said to CMS. And you can see there's an example. You know, we talked about what do you need to think about if you're considering expanding telehealth or virtual services or remote support technology or family members as paid support, electronic signatures, and administrative functions. So those are kind of the 6 things that I highlighted for the purpose of our presentation today. Okay, so moving on to our next topic. This is kind of a very boring title for, holy cow, we just went through a pandemic and discovered that our home and community-based long-term care system, you know, I think we learned things that we didn't know, or we knew, and it just really highlighted that we have some things to change. I think when we think about, like, where are the opportunities to really systems change, we got to remember that everything that we think of as familiar and the way things are is different somewhere else, first of all, because every time you get a group of states in a room, they'll go, well, in my state, this is how we do it. And somebody else will say, well, that's not how we do it at all in my state, right? So we've got to remember that everything we know to be familiar isn't necessarily the same elsewhere. Somebody else has had a different idea, and or it didn't exist before. Somebody thought it up, which means that somebody can have new thoughts like us and change that system. And it can be small changes or it can be pretty big ones. And you know, we're DD Council, so we're systems change agencies. So I like to think we're on the forefront of big change, even though we don't always get our way all at the same time. So there are a lot of things that states have control over when it comes to how they think about operating their long-term care systems. Most people think about those Medicaid waivers that we've talked about, those 1915C waivers, but I want you to think about that really creatively, because, you know, when you look at the kinds of things states do with waivers, which are essentially permission to deviate from the basics of Medicaid law, there's a tremendous amount of flexibility there, almost unlimited. You can add services. You can decide to have more waivers or fewer waivers. In our state, not to violate my own rule, our home and community-based waivers cover people with intellectual disabilities, people with physical disabilities, and older adults. And man, it is the best thing ever, because all of those populations' needs are considered under one waiver. We have a kids waiver, family care waiver, and a self-directed waiver. 3 waivers, boom, we're done. Other states, yeah, you may have 7 to 10 waivers. You know, you can think about, are there different models that make a lot more sense? Do you need more waivers or fewer waivers? Do you need more services or fewer services? Do you need changes in your definitions of services to make them more expansible in terms of what they can pay for? There's a tremendous amount of flexibility with waivers, and in many states, it's almost all administrative. In other words, it's almost all within the power of your state Medicaid agency acting within its authority, and you probably have the governor who has, you know, some responsibility for saying, yeah, that's a good idea or a bad idea. You can expand to whole populations of people. It's really almost an unlimited, it's whatever CMS will approve. And they've approved a lot of different things. In this administration, I think you might have some real opportunities to test what they will approve. In fact, I learned this morning that our children's long-term support waiver is applying to CMS, and they are actually apply in their waiver application. They've said we want to be able to offer a service that pays for not only the technology, whatever technology people need to connect to the internet and virtual services, but also the internet connection themselves. That is something that is a huge issue for a lot of states that CMS has said they won't pay for before. Wisconsin's asking. and hopefully the answer will be yes. Medicaid plan amendments, same sort of theory, where you have a lot of flexibility as a state to decide to do more than what the minimum is required by federal Medicaid law. And we kind of just had this discussion about, states can choose to make better budget investments. They can choose to make legislative changes that make people's lives easier. These are all pathways that can really be used to help evolve community services to be more community outcome oriented or protective of people who are in long-term care. I'm going to talk about three things specifically. For those of us who've been around a while, the home and community-based settings rule is still out there as something a lot of states haven't completed yet. And we kind of just had that conversation about there's new money. Not only the FMAP increase that's been part of the previous couple of COVID relief bills, but also states receiving funding from the American Recovery Act, and there's a lot of discretion on how states can spend that. So I'll start with the home and community-based services rule, and I'll explain to you why Wisconsin's thinking about this. The home and community-based settings rule is really coming from the 1999 Olmstead decision. And rule was first promulgated by CMS in 2013. And it was promulgated about the time I started with this DD council. And that states have until now 2023 to develop a transition plan and implement that rule. And as we were looking, we just recently had a public comment period because our state's transition plan has changed enough that they need to do a public comment period. But this is the first public comment period after COVID. And a lot of advocates said, you know what we realized after COVID is that we are so over-reliant on congregate settings, and that the congregate settings themselves, while smaller than the large-scale institutions of the past, many of them have some of the same problems. So we're looking at this home and community-based settings rule in a very different way post-COVID than I think we were in 2013 when we submitted the initial comments on the rule, which of course is very depressing for me to note that I've been literally commenting on this rule for 8 years now. So, I think it's, you kind of have to sometimes reevaluate where your opportunities are. If you're advocating for waivers that are more flexible, services that are more reflective of what we want the outcomes for people with intellectual and developmental disabilities to be, more community integrated employment, more community integrated living, more supported, people who are supported to be in their own places as opposed to group homes or adult family homes or other kinds of provider controlled settings, then the HCBS rule may not look like it goes far enough. So we used our public comment period to do a couple of things. We basically said, this is another opportunity for us to talk about how do we how do we modernize our whole home and community-based system to look different than it does right now? Because, and I actually quoted some of the language that we prepared. We toned it down a little bit, but not a lot. What we found is that the home and community-based settings rule is for our agency is really about how do we make the existing system fit as acceptable within the confines of this rule. And that isn't system evolution. That's finding a way to make sure that the existing things that we do are continued to be allowable. And if we're in a space 8 years later where we're starting to evaluate some of the existing things that we do as not being the stuff that we want to do forever, this becomes a more important venue to comment, because if you start locking in what's acceptable as being an old model that you're kind of now moving away from advocating for to advocating for something new, that's actually important. So we really tied it together to say, look, the size of the setting isn't necessarily the determinant of whether something is institutional or not. There are institutional practices that really inhibit people's ability to make their own choices. And we gave them a list of all the things that we were hearing about, especially during COVID. I mean, there were people who were not allowed out of their group homes for almost a year. and we happen to have we're one of 6 states that got a chunk of money focused on abuse and neglect prevention. So what we're finding out through that work is that there's a lot of things that people experience within some of these smaller congregate settings that really aren't that different from the experiences that people have talked about in much larger scale institutional settings. Restrictions on what you can do, whether you can leave the house at all, what choices you can make in terms of transportation, or whether or not you're allowed to have something because someone else in the household is not allowed to have it. And I could go on. During COVID, a lot of these problems that were always present became more obvious. So we really pushed on, we have to figure out a way to transition to a model that is not the same. And we actually tied it to some of the other things we're going to talk about, where if we want to start doing service delivery change, not only should we be rethinking whether or not these things are acceptable enough in the state's eyes to comply with the HCBS rule, we should be using the money available right now to transform the service system. There's kind of 2 pots of money going on. One is, when I say FMAP, that actually stands for Federal Medicaid Medical Assistance Percentage. As most of you know, Medicaid is a state and federally matching program. So the feds put in roughly 60%. For some states, it's more. Some states, it's a little less. They roughly put in 60% of the total cost of whatever your Medicaid programs are. And the state antes up about 40%. The COVID relief bills essentially increased the amount by 6.2% of what the feds put into your Medicaid systems. So that meant the states didn't have to put in as much of their own money. The feds paid for more of whatever the cost is. And that's a huge deal for states. I mean, it's hundreds of millions of dollars in a lot of cases. And because of that, that bump up in the amount of federal aid that the feds are providing, it means that you're getting additional money that you can invest, including making investments in home and community-based services. So I gave an example of Wisconsin. that 6.2 FMAP bump for us net translates to $350 million extra dollars in the first 6 months of this year. President Biden has said that FMAP bump will continue because of his authority over the federal emergency declaration, at least through the end of this calendar year, which I'm like, there's an additional $350 million for us. And you can look on Kaiser Health News, they often do a breakdown for what states will get. That's a lot of money. In addition to the FMAP increase, which by the way might be permanent if the Better Care, Better Jobs Act goes through. I think one of the proposals is to make that increased FMAP bump a permanent part of what states, so states contribute less to their Medicaid systems and the feds pay more. In addition to the FMAP increase, there's also this big chunk of American Recovery Plan Act money. And governors have really broad discretion on how that funding is spent. Some of the ARPA money is formula based. So there's transit's getting stuff. Local governments are getting stuff. Local school districts are getting stuff. But each state is receiving a hefty chunk of funding that they have discretion over where to distribute it. And that again is a potential place where you could make a case that improvements to home and community-based services could be funded. ARPA, by the way, also includes a 10% FMAP increase. So you can see that FMAP increase continues through May of 2022 and potentially further if the Better Jobs, Better Care Act goes on. So there's like a lot of dollars here. There was a nice article, and there's a link in the left-hand column about what are examples of activities states could use, some of this funding for. And a lot of the things that you've had questions on are right there, right? Raise worker compensation. Here's build systems, increase provider capacity. There's just a tremendous amount of opportunity if you're thinking through on the front end of what you could potentially use these kinds of dollars for. Now, everybody gets excited when somebody else wants to pay for something. I get excited. I want people to pay for other things, for everything I want to do. But there are some catches. These are one-time allocations, right? So even the FMAP stuff, at this point that increase goes through May 2022, and there is no guarantee after that increase continues, right? That's hard to do a sustaining program operation with money is going to expire. It's got to be spent within a certain time frame. It's about 4 years. So when it comes to if you need a source of bridge funding for ongoing needs, with the idea that you are going to find sustainable funding when this money runs out, that may be an option for you. And depending on your legislature and what they want to invest in and your amount of advocacy and commitment and ability to get them to continue to spend their money when this money runs out, that might be an option. It's also possible that you spend the money that you're allocated here and the state says, we don't want to spend any of our money, and then all of a sudden you have a big hole. So, some of us have been around to have both scenarios happen. But there are an awful lot of things that are time-limited projects that are good investments and that might position yourself to be in a better position to advocate for a greater share of dollars or for additional share of dollars. I'll give you an example. Technology systems are one of the things that are the hardest to get funding for. There are a lot of states that have explored different variations of caregiver registries. I kind of describe them as dating apps for like how do you find a caregiver in your area and who has availability at the time you need it, and who's a good match for you. How do you find caregivers, and how do caregivers find you? That's an example of a technology system that actually exists that a lot of states haven't had the ability to test out or try. We have an appalling adult protective services system, for example. There's lots of things that through neglect and lack of investment have become a real impediment to a well-run system. This might be a way to remedy some of that neglect. There's also, councils are really great about knowing the investment of small amounts of money to try and test out new ideas. Pilot programs, things you've been thinking about for a while, things that you haven't been able to sell the department on, or you don't have the proof that there's the return on investment because not enough people have done it. We run into that with a lot of housing stuff, like community supported living. Is it less expensive? Sounds like a great talking point. And then somebody asks you what study or pilot program has been done. And it's like, well, we have examples of individuals, but there isn't like this peer-reviewed statistically accurate study. That's something else to think about. Like, what are the pilots that you can design? And of course, there are always things like anytime there's an opportunity to ask, whether you're asked to ask or not. We've certainly been communicating with both our state Medicaid agency on not only how we think the FMAP money should be used and reinvested in our long-term care programs, but also to the governor's office. And sometimes we're asking them to do the same thing because we found that our Medicaid agency and our governor's office don't talk to each other, right? So there's no harm in repeating yourself. If it's a need that you can authentically say, this is what we're hearing from people with disabilities and their families, the important part is the asking, and the asking for the right thing. And you've got money to do it, and you should be doing it one of two ways, right? So I don't want to, do here's what Wisconsin did, but here's some examples of what we asked the governor to do. And you can see that, yes, we absolutely have a lot of things in the suite of long-term care. Our home and community-based services, this is kind of our waiver programs. We broke out, what should you be doing for family caregivers? What should you be doing for the caregiver workforce? Employment. Everything in green, by the way, is something that the governor did with our ARPA dollars. We also asked, this is our children's waiver. We asked our Department of Public Instruction for stuff. We asked for, things that would help non-drivers. And then we turned around and asked our state Medicaid agency for some of the same things, but many more items that were directly related to long-term care. And you can see that we got a few wins in there just by asking. And I don't think that had we not asked, that those would have been wins. I think there's a real challenge in our state, maybe not others. Provider agencies tend to want to ask for a lot of funding to support what they already do. And they're very vocal and they're very loud about it. And sometimes those asks align with advocates and people with disabilities and their families and say, yeah, that makes sense that you don't want to go completely out of business, right? Like there are things that make sense, but oftentimes providers don't necessarily have the same goals in mind. So we always find it's very important to make sure that there's a robust suite of voices. And the only way we can do that is by proactively asking. So we have a few minutes here, and these are just, again, some of the questions that I came up with. But again, the floor is open for states about things you're seeing in your state and what you're thinking about in terms of how do you use this moment in time to evolve your system.
A big issue that we're seeing in Michigan is the access to affordable and accessible housing. Can you speak to how the home and community-based services funding could support that, or could support that.
Yeah, housing. Brett Williams and I have had these discussions. I will say again, from our children's waiver tends to be the most innovative waiver. They, in many ways, are driving the discussion. One of the changes that they made, and they're asking CMS for permission to do it, is specifically on housing. And they're really broadening out the definition of how do we help people. You know, it used to be a very narrow, like, we'll help you relocate, which kind of sounds like moving from one institutional setting to another. And they changed to be much more expansive and to really say, we, you know, how do we help people with disabilities figure out a transition plan to move into their own community housing. So it's much more like a Medicaid, almost a brokerage service, where you're helping people navigate into independent living as a service of the waiver. And
do you think that's going to include you know, for people that have lived in the community as people with developmental disabilities for some time, and let's say they need to make adaptations to their current living environment, you know, to plan for like aging in place, is this funding going to support that as well?
You know, you're raising an excellent question that could be addressed in a lot of ways. I think that's something that many state Medicaid agencies aren't thinking about, is how do you keep populations who are in community-based care in their homes as long as possible. Certainly we have asked for, there's a lot of people who say got moved out of group homes into their parents' homes who need to move back somewhere else, and we'd like it to be in the least restrictive setting possible. So there's that money follows the person type idea. But there's also what you're saying, which is who pays for the adaptive aids, right? And in our state, we work fairly closely with a lot of the aging advocates. So there are different pots of money under the Older Americans Act that are available. There are some things that the independent living centers do. Everybody would agree it's not enough money for the need that's out there, but certainly you could change your waivers.
I mean, by Medicaid manual, it says that they will pay for, you know, adaptive equipment to cover somebody's ability to remain in their home, but it's not clear to what extent, you know, the coverage of those modifications would be supported. So
yeah, I think that's a great, and again, you know, one method is to clarify that in your waiver, right? Make it as flexible as possible, because you absolutely want, you know, if anything you need to remain in your home really means anything, no matter how much it costs, well, okay, that's great if people know that that's what it pays for. But if you need to make sure that people understand it's for, you know, as your disability changes or as you age, you know, that you can clarify that.
Thank you.
Other thoughts that people are having? Otherwise, I can move on to the next section and we will have a little time at the end. You guys are a very contemplative group today. Or you like the sound of my voice this afternoon.
Sorry, I have a lot of thoughts as we've been going through this. I've just been pondering. This is Jamie in Alaska. I know we're out of time really, but sometimes when I see some of the proposed ideas, I'm trying to piece together how it's connected to the emergency relief funding. Certainly these things are needed, but I'm just absorbing everything that people are saying, trying to put all of it together in my head.
Yeah, I'll say that we've never had an opportunity where we've had like multiple paths to potentially getting funding to do systems change at the same time. You know, so it is a game of leapfrog.
I feel like it's a good problem to have. You just have to understand what maybe it's not this simple, but understand what the parameters are within those pieces, and kind of fit your ideas into those parameters when you're
So I'm actually going to push back on, not on you.
Yeah,
not on you, but I'm going to say it's not your job to know everything there is to know about your waiver or federal Medicaid law or anything else, because I get that all the time from my state Medicaid agency. Well, can we do that? Well, you're the people who have the phone that connects to CMS to ask the question. You know, our idea, our real role is to say, look, these systems need to work better for people. And here's what the people's challenges are. And here's our questions. And here, yes, absolutely, advise them on like, here's things we think you can do. But don't fall into that trap of, you know, give yourself permission to not have to know everything before you make the ask. Because these bureaucrats have jobs and they get paid. And part of their job is to make sure that the systems work for real people who are in them. And that's part of our role, is to remind them of that.
That's totally fair, and I feel accurate. I come at it from a two-piece lens. I'm a self-advocate and also a social worker that works on behalf of people with disabilities. So I have an interesting lens on both sides of it.
Well, and you've kind of been conditioned that you have to have all the answers before you ask, right?
Right.
Because you get dismissed right away. But sometimes like, you know, you got to be persistent in saying to people, look, this is the issue and here's some suggestions, but you've got to tell me what's going to work, and I'm going to keep asking you.
Right. That's a good way to go about it.
Tammy, before you move on, there's something in the chat from Kristen. She said she's not able to turn on her video or microphone, so I'll just read it if that's okay.
Yep.
She said, in Nebraska, we tried to have the legislature pass a family support waiver to cover the needs of children who are on the state's wait list / registry for DD waiver services. Typically, they have to wait until age 21 to qualify for adult day services. Legislation failed, really disappointing. Governor not in support of even a pilot to address the unmet needs. Our legislature has an interim study this summer and fall to study the needs of our waivers. Hopefully we can leverage the study to fund a family support waiver. Sounds like we need to argue for ARPA or FMAP funds used in this area. Current FMAP investment plan is going to providers and technology infrastructure.
Yes. Well, and I do worry, I'm not alone on this, I don't think. I do worry that a lot of this money is going to get eaten up by the easiest thing to spend money on is what you already spend money on. So I worry that our providers are going to get a boatload of funding, and that funding isn't going to really result in a bunch of change for real people, because it's hard to spend money fast and it's hard to spend money well. So I sympathize with you. I'm from a state that does not have wait lists for adult long-term care anymore. And we kind of are skating the edge where we might not have that for kids. But I will tell you, it took us about 15 years for kids, and it took us almost 30 for adults. And you know, our legislature is pretty conservative. at the moment. And we really had to make a return on investment argument that keeping kids out of Medicaid actually just costs you more overall. And that's a kind of icky thing to have to think about, because most of us are from the position of this person needs some help and this program's designed to do that. So why aren't they in the program? But that isn't the decision-making metrics that often dictates how money's spent. We have a legislature that wants to know how every dollar is going to come back as being well spent. And that's part of the case that we make every time we go on. Okay, this is actually my shortest section. So hopefully we will have time to do some discussion afterwards. I put this in because, you know, again, we have pots of money that can be used differently than we did before. And, you know, every advocate has their things that really bother them. I have about 4. One of them is there are 3 remaining state institutions in our state. And I know other states have large scale institutions, state-run, state-funded, state Medicaid funded institutions still operating. Some states are actually still fairly reliant on that model. Others, you know, like mine are it's really a remnant, and there are other states that have completely closed these state operated settings. But that's not all when it comes to institutional settings. A number of states have also seen a desire to use Medicaid funds to build segregated communities, sometimes called gated communities, that are only for people with developmental disabilities. So it's kind of a different flavor of what we would associate the model, the institutional campus model being. It's just perhaps, you know, maybe there's some private dollars involved, maybe there's not. And then of course, we've already discussed, like, some of our home and community-based systems, especially in the upper Midwest, really have a lot of reliance on congregate settings. So most of our folks are moved out of large-scale state-run institutional settings, but they're living in a group home and being shepherded to congregate sheltered workshops and day services. So how is that functionally different for a lot of folks in their lives? And there certainly are some highly placed and well-funded folks who really, really see value or see threat to institutional settings by better funding for home and community-based settings. In fact, there are advocates for institutions who said, well, wait a minute, if home and community-based settings are getting an increase in the amount of money they get, well, our institutions should get an increase too. And that is certainly not the message that we want Congress to hear, right? The model of institutional settings has been the de facto model for people with disabilities and is required to be funded under Medicaid. Home and community-based settings are completely optional under Medicaid law and have never received the kind of investment that's proposed under the Better Care, Better Jobs Act. So I do think this is, again, a time where we all thought this topic might be a little less prominent, but there is probably a need for vigilance here. And, you know, as you're thinking about how do you advocate for a piece of the FMAP funds or a piece of the ARPA funds, an important part of the messaging is reminding people why living in your own home should be the default option for everybody. All of our decision makers now, they don't know about the Olmstead decision the Supreme Court made in 1999. They maybe haven't thought about what they're going to do with mom or grandma when she can't live independently in her own home or she can't drive a car anymore. You know, there's lots of very valid, very good reasons why people without disabilities don't want to have to move into a congregate setting, and that holds true for people with disabilities too. In our state, people voted with their feet. When there was an option to live in the community, they did. You know, That's an important thing for folks to remember, is that, you know, we hear all the whining. Can I say that? You know, our nursing homes have a very effective lobby. They're very effective. And nobody wants to live in a nursing home. And yet we know how to give money to nursing homes. And so that is what our legislature does, right? And they don't understand the home and community-based waiver system because it's dispersed across the whole state. You have people who are living in their own homes. So now more than ever, it's really important that people understand not only the value in state dollars saved when you don't put people in a Medicaid funded facility, but also all the reasons for health, for safety, for having outcomes like you can't be, you know, employed in the community if you live in a nursing home, for example. All the things that help make your Medicaid dollars go farther or help you spend fewer Medicaid dollars, they're all in the home and community-based system. They're not in the institutional system. So I only had 2 slides for that, and we have plenty of time on the back end to talk about either these questions or other thoughts that you're having. And I'm going to stop talking now. We have about 20 minutes at the end. So I'm going to turn it over to you guys.
This is Anna again. I was just thinking, a lot of times when we have conversations about the benefits of community-based living, we talk about the comparison of the price tag that is associated with having somebody in the nursing facility versus in their own home and engaging in the community of their choice. And it's not only a cost effective approach, but it also improves the quality of life, as you've been indicating in a lot of your examples. So,
you know, and I think when I think about our state's advocacy, we have a very conservative legislature that's really worried about return on investment. So we do compare, because, you know, people forget that our waiver program is compared against institutional costs. If this person has an institutional level of care, what does it cost to institutionalize them versus be in the waiver? And that's, you know, that's an institutional bias that's in the Medicaid program right now. We've often talked about, like, even over time, how much does it cost to put somebody in a nursing home, like, or a state facility? And we've extrapolated over time. But the reality is, we have not done as good of a job of quantifying what does it mean for the person to be able to live in their own home versus a group home, own home versus an adult family home,
yes,
own home. You know, what does it mean if they can be employed at a community integrated job? And I think we've written a lot of discussions about, well, now that virtual work is an opportunity for a lot of our folks with physical disabilities where transportation is a challenge, maybe there's a whole world of opportunities where, you know, people who are using a whole variety of home and community-based services, thinking about this from a person-centered planning. I don't think we've figured out how to do the return on investment for all of the things, you know, all of the outcomes that we say we want people to be able to have, you know, that really match the lives of people without disabilities. There's a huge amount of savings there that we don't talk about because we've gotten used to comparing what we know the cost to be if people are in a setting that has a provider that needs to be paid. it's okay with folks, I'm going to stop sharing my screen just because I can't see any of you when I'm sharing my screen. So now we are in a setting where we can have more of a conversation face to face.
Hi, I'm Margaret Hooper. I'm with the Florida Developmental Disabilities Council. I do their public policy. I've been doing it for almost 17 years. And I just want to tell you that this was a really great presentation. I thought it was very thorough. I thought you really did make it open to what other states could do, and that's not an easy task. And how I'm going to use it is I'm looking at what have we done and what could we do better in terms of engaging the Agency for Healthcare Administration, who does the Medicaid applications, and the Agency for Persons with Disabilities. So for me, it's been kind of a checklist of, okay, what have we done well? Well, we did really give a lot of input on how we wanted that Relief Act money, but we could do better perhaps on some of the flexibilities. How can we keep those? How can we talk about keeping those flexible provisions, especially if they don't cost anymore, in place? So I just wanted to thank you for that.
Well, I'm glad that it's useful, and if it's spurring different ways to do things, you know, we're always needling for where's the opportunity, and anything that you can get in your PPR, right? So I see, I'm going to read Kristen Larson's stuff. Man, Nebraska, I feel you. Maybe we can all crowdsource for Nebraska here. Nebraska, they have advocates who are promoting institutional congregate settings at the former state institutions, which are now broken up into ICFs. Suspect that that's tied to the national of it with the Voices of the Retarded or Together for Choice. And they argue that the HCBS system fails for people who have medical complex issues and challenging behaviors. So they're promoting the ICF model for, you know, a subpopulation of people with disabilities, which sounds very much like, well, there's people with significant disabilities or people who are too disabled where this is the model that should be right for them. And as many of you know who've done public policy work and have heard that line before, as soon as you admit that there's some population of people with disabilities that this is the right thing for, that population often expands into different things. So I guess for Kristen, you know, we run into the same problem when we try and argue closing our institutions. And I'm in a state where there's no adult waiting list. And I can tell you that there are states that have closed their institutions and states that have good home and community-based systems. There are, you know, we haven't had a long-term admission since 1984 in Wisconsin, 2 states away. And there are a lot of very medically complex people who are in our home and community-based care system. So we've managed to figure it out. And I think there are other states that don't operate institutions that have managed to figure it out. I have no doubt that the messaging from those groups has been effective in your state, especially since, you know, if you don't already have a strong home and community-based waiver program, you know, you're arguing for investing more in something that isn't robust enough when there looks like there's a ready-made solution that's easy to pay for. But it's, you know, sometimes you just gotta figure out how to reject that narrative. And there's certainly other states that could probably provide you information on how they've done that.
Oh, this is Steve. I'd just like to weigh in. I think you've done an excellent job on your presentation. You've got you've gotten me thinking about a lot of different things. I mean, we've been engaging with our state agency on different ideas, but I really think you brought a few points up that I really hadn't thought of before. And I haven't had the issues that Nebraska's dealing with yet, but I'm assuming that if they're firing up in Nebraska, we'll probably see them here in Kansas too. And I do want to make a comment. Before I came to work for the council, I worked for a provider, and we served people that had just as tough services or needs as anybody that we have in our institutions, both with behavior and medical needs. And it wasn't always easy, but it was possible.
We could probably go on and on about some of these topics for a long time. So I don't want to like spread out my concerns for the future, but I am very concerned about institutional settings kind of getting a resurgence. One of the things that's kind of an unknown secret is that even in states where they're no longer accepting new admissions to our current state institutions, which by the way are crumbling. Like part of the financial reason why there's an incentive to close is that you've got few people living there and the facilities are not habitable in some cases. But one of the dirty secrets is, well, if somebody really wanted to institutionalize their person, they could go to another state that's operating an institution and our state would have to pay for that. So I do worry, like in places that figure out financially their institution is in trouble unless they get a bigger population. I really don't want people to be going to Nebraska and Kansas from our state to go to an outdated model that isn't good for people because we're trying, you know, like there's an ability for that messaging to work.
This is Anna again. I'm wondering what your thoughts are on the oftentimes the group home model that's like the intentional community model, which is often used for people with developmental disabilities. Do you see home and community-based services supporting that or rejecting that option? I'm not saying that I support it. I'm just saying that it's out there as something that families are using as an option.
Yeah, I mean, I think in where we are in our state, we are overly reliant on group home settings, and we have a service package that is robust and is supposed to be supporting full lives into the community. So like my person-centered plan, we cover every service that's offered under Medicaid in Wisconsin, which isn't the case for other states. But in my personal plan, if I say I want to do community integrated employment, I should be able to do that. And what frequently happens is that vision of the outcome in the group home, because you have limited staffing and multiple people, the choices individuals have often is very different and more limited than what they might say they want in their plan. And that's what I worry about, is that it dresses it up in language like there's going to be choice, But unless you build in the actual ability to do individualized support to that person's plan and have it paid for, it doesn't happen.
Mhm.
Or the setting itself and just how it is run, the policies and the operational pieces of it don't actually fulfill the plan. And Steve, I saw your hand up, so please.
Yeah,
weigh in.
I want to jump in on this because, well, I want to direct you to what's behind me. You'll see a building behind me.
Yeah.
That is the school where the Brown v. Board case was all about. And in the Brown v. Board, it was in 1956, they were looking for a school that was a Black school where they wanted to see that the services there were equal. And this is a school that's in Topeka, Kansas, and the classrooms are the same size as the white school. The teachers were just as qualified. They had just as many books. Everything was equal in this particular community. And this is what the court case was really about on Brown v. Board. It really wasn't about whether or not they were getting an equal education, because you could make the argument that they were. But the principle and the findings of the court on this particular case was that separate is never equal.
Mhm.
And it's separate is never equal is the whole point. And I think that's the civil rights basis that we've got to always look at as we move forward, that separate is never equal. People belong living in the community in their own homes and family homes. And we've always got to keep striving for that. I think that's the basis of the civil rights foundation that we have to work from.
And as I think about the questions that we kind of had on the screen, we didn't get to them. Like, those are the discussion questions that I'm thinking about. And I have a really, really simple metric of how I do public policy. If there's a public policy that if it was applied to a person without a disability and it wouldn't be okay, it's time to evaluate that policy. And I think when we think about a lot of the services in home and community-based care, I don't think that me as a non-disabled person, it would not be okay if I was sent at 18 to live in a congregate group home with the expectation that I would never necessarily leave there, and I would observe whatever the rules are for the paid staff that's there, and I would commute to the sheltered workshop, and that would be my job. That would not be acceptable for a person without a disability.
Yeah.
So why is it for somebody who has one? My other simple litmus test is, does this policy make things better or not better for people? And if you believe in the idea that civil rights, the ability to make your own choices, the ability to do something that you are good at, that you enjoy doing, and to be able to waste your time however you want, like, not every moment has to be approvable by somebody else as being a good use of your time. If you believe that those things, which are all perfectly allowable and expected of people with disabilities, should be things that people without disabilities have, then you have to create a system that makes that path attainable for people with disabilities. And I am no longer convinced that is really where our system is, in terms of, how we have designed our service packages. It's time to evolve again. If the ADA is 31 years old, and it's a piece of civil rights legislation, and it's supposed to guarantee equal access and equal opportunity, I think it's time to take a hard look at our systems and go, well, do they do that? Olmstead was in 1999, and it basically said states can't use the logic of, we don't have home and community-based system to keep as a reason to keep you institutionalized. But Olmstead should go, it goes beyond just that. And I think COVID, at least for our state, especially since we're doing so much abuse and neglect work, it's really brought to the forefront how limited some of people's lives are and their choices are within the system that is supposed to be paying for you know, a community life like we expect everyone else to have. I'm going to type my email in the chat. This presentation should be part of the packet you guys can access, or links you can access after the fact, but you can feel free to email me at any time. Again, I'll make one more pitch, and I saw that there was a thing in the chat for Jeremy Norden-Paul, who's the ED of Washington State. He has a, I think, bi-weekly state peer-to-peer, just kind of policy talk shop. He usually picks like a topic, and maybe there are a couple of questions. I would encourage anybody with an interest to kind of pop in on those calls. They're usually on a Tuesday afternoon. I think a lot of states have found it to be a useful way to share information and share kind of the case study, the case studies and things that they're doing. So Jeremy, there's Jeremy's, he is the state peer-to-peer policy group. And there's no pressure, you just show up. And sometimes people show up and they go, hey, I got this problem, and have questions, and it's a way to crowdsource with, you know, other policy nerds. So feel free to reach out to me with any, and we'll help you as we can. Wisconsin tends to produce a lot of documents, so if you contact me, it's probably you'll come back with an attachment. And otherwise, we are at 4:30. So if folks have different places to be, different sessions, go forth, be free. It was great to have all of you this afternoon. And I hope to see you in person or virtually sometime soon again. Thanks.